Hello, my name is Joel Chong, and I want to talk to you today about perioperative patient management for basic dental implant surgery. And before we start, let me start with a brief introduction of myself. After dental school, I completed an AGD residency in the Air Force and spent several years as a general dentist. And then I pursued training in periodontics and spent the next 20 years primarily in dental education. And I've taught all aspects of perio and implant surgeries to both AGD and perio residents. And then for the past 5 years, I've been in full-time clinical perio practice. And one thing that I've learned as an educator early on is that I really shouldn't apply my level of experience to someone who's just starting out in their surgical journey. And I can't forget to address the basics. And that's why today I want to answer the questions which many novice implant practitioners may have, such as how to take care of patients after implant surgery in order to manage their pain and prevent post-op complications. So, just to start off, the definition of basic dental implant surgery is an implant placement in an intact ridge with no additional bone augmentation needed at the time of implant placement. Okay, so this is your straightforward implant surgery for your novice surgeons. And the three topics I'll be covering today are postoperative analgesics, perioperative antiseptic rinse. And you notice that I've used the term perioperative, not postoperative, because we're we want to address both antiseptic rinses immediately prior to surgery as well as post-surgery, and likewise perioperative antibiotics. So the question that I want to ask regarding analgesics is how painful is dental implant surgery anyway? So here's a recent study that have looked at basic dental implant surgeries, most of them single implants, and then coupled with few multiple implant surgeries. And in this study, they gave out 2 tablets of 400 milligram ibuprofens. That's it. And 89 patients used the analgesics, but about 48 did not use any of the analgesics in this study. And then patients were asked to give an assessment of the level of pain that they've experienced based on a numerical pain rating scale of 0 to 10, 10 being the worst pain you ever had. And the greatest postoperative pain was noticed at 24 hours after surgery. But even then, if you look at the score, it is negligible at less than 3. Okay? And then after that, 72 hours after surgery, the amount of pain that the patients are feeling is extremely low. If we look further into the study, we can see that about half of the patients did not even experience any pain. And why is that? I think it's because the bone itself has very little nerve endings. And once the soft tissue is numb, you can do a lot to the bone without the patient feeling pain. Case in point, back in the days when we didn't have access to CBCTs as readily as we do today. And in fact, when I first started, um, we had to get a full CT, a medical grade CT, if we really wanted a cross-sectional uh, view of the patient's jaw. So in those cases, when we were getting close to an inferior alveolar nerve, a lot of times what I would do was I would actually anesthetize the soft tissue in lieu of a total block anesthetic, and then elevate the flap and actually drill into the bone until the patient started feeling sensation, or until I got to the depth of my osteotomy. So in that experience, I can tell you that that the bone has very little nerve endings, even if it's not completely numb. All right. So if the patients do not feel much pain after dental implant surgeries, what about narcotics? Do we even need to prescribe narcotics for dental implant surgeries? when I first started it in dentistry, we were weary of prescribing heavy-duty narcotics for pain management. And then we were told that as a profession, we tended to be too conservative in pain management, and that the and we would let the patient suffer too much because we were afraid of the risks of narcotic use. But then the pendulum swung to the other side, and for a time, my residents were routinely prescribing hydrocodones to patients like candy. But since the narcotic addiction crisis, we have had to ask the question as to how can we better manage our patients' pain while weighing the risk of dependency on narcotics, okay? So let's look at what the evidence says. In this study, looking at the pain relief different medications can um, can achieve after third molar extractions, we noticed that the combination of ibuprofen and acetaminophen is the most effective at managing pain relief than anything else, including acetaminophen with codeine. Another study that have looked at the management of postoperative pain. This is a 2023 systematic review. Now, first of all, a systematic review is not a primary research, but it's a review of available evidence. And a meta-analysis is using the systematic review data and plugging it into a statistical model and giving us a statistically relevant information. And depending on the criteria and the focus of the systematic reviews, in many cases, meta-analysis are the highest level of evidence we have, even above randomized controlled trials. So in this systematic review and a meta-analysis, what we have found is that based on moderate and high certainty evidence, NSAIDs with or without acetaminophen results in better pain-related outcomes than opioids with or without acetaminophen. So if we combine all of these studies that are out there, ADA has recently came up with an acute dental pain management guide that was published in 2024. And its primary recommendation is the use of NSAIDs, either ibuprofen or naproxen, to manage postoperative pain. Um, and in addition to that, they also recommend ibuprofen and acetaminophen in combination as well. Now, what about patients who are unable to take NSAIDs? Well, in those cases, the primary recommendation is for the use of acetaminophen alone. Now, in more severe cases, acetaminophen in combination with oxycodone and hydrocodone is recommended. Personally, what I've done is that in those rare occasions where I had to prescribe a narcotic, uh, my primary go-to narcotic is tramadol. First of all, because it is a Schedule 4 narcotic, has a very low risk associated with it, and the chances of patients getting any money trying to sell it uh, aftermarket is fairly low, has less complications than codeine, and it's fairly easy to prescribe, and you can tell the patients to combine it with acetaminophen. Now, what about perioperative antiseptic oral rinses? Now, there are a lot of options as to what types of uh, oral rinses that you can give out there. You have a lot of over-the-counter products, including Listerine. However, when we look at both plaque reduction and gingivitis studies, chlorhexidine dominates in both plaque reduction and gingivitis reduction, and it is the go-to, is the gold standard of oral rinses for both pre and post-operative uses. This is a study that actually looked at a large number of dental implant surgeries, and the patients were divided into those that have used 0.12% chlorhexidine rinse pre-surgery, and then used twice a day for 2 weeks versus no chlorhexidine use at all. And when we look at the results of this study, we notice that the infection rates of chlorhexidine use group was significantly less than the non-chlorhexidine rate groups. In fact, it is less than half. And when we also look at the implant failure rates, whenever there was an infection, the failure of implants were significantly higher than sites where there were no infections. So in conclusion, the study states that the perioperative chlorhexidine rinses reduced infectious complications and that implant failure significantly associated with infectious complications were noted. Thus, chlorhexidine oral rinses may be beneficial in reducing microbial-based complications and therefore reduce the number of implant failures. Now, let's look at the evidence for systemic antibiotics. Do we even need to use systemic antibiotics in straightforward dental implant cases? Well, first of all, which antibiotic regimen should we be using? So there was a survey that was sent out to the American College of Oral Maxillofacial Surgeons on antibiotic uses for routine dental implant surgeries. Now, when I say routine, once again, these are straightforward dental implants without any additional bone augmentation. And what we find is that about 50% of the respondents reported using pre-op antibiotics, and then about 70% prescribe post-operative antibiotics, and then about 34% use both pre and post antibiotics. And the antibiotic regimens that was most common were the uses of 2 grams of amoxicillin, either 1 hour prior or immediately prior to the implant placement. And for the post-op antibiotic uses, typically it was amoxicillin 500 milligrams 3 times a day for 5 to 10 days, which was the most commonly used antibiotic regimen. So in conclusion, the perioperative use of prophylactic antibiotics and dental implant placement continues to be widespread and variable. There are a lot of different options, and we don't really truly have a true consensus in what's used. But what does the evidence say? If we look at the benefits of antibiotic usage, only one um, regimen of antibiotic really stands out, and that's the amoxicillin 2 grams 1 hour before. Now, this was the result from the meta-analysis from Esposito. This is a report from the Cochrane database. Now, if you've never used a Cochrane database, this is a very useful site that you can actually utilize in your clinical practice as well as in your personal lives. If you have any health-related questions, you can go there. You can ask questions such as, if I need a gallbladder removed, is an open approach better or is a laparoscopic approach better? And then it would be able to give you an answer based on the systematic reviews of all the evidence and all the literature that's out there. So in a similar way, so the Cochrane database gives us this answer as to the fact that the amoxicillin 2 grams gives us a statistically significant benefit over no non-antibiotic use in implant dentistry. Now, just because something is statistically significant doesn't mean that that it's readily translated into a clinical practice. Especially in medicine, there are a lot of drug companies that are trying to sell to the doctors that are new medications that they've developed is better than an older one. So they do a lot of research and a lot of studies to prove to you that it's statistically significant. However, it is very difficult to translate that and say, hey, what does that mean clinically? So there is a clinically relevant data that is called number needed to treat. And basically, if you give a number needed to treat of, let's say, a 50, what that means is that if you treat 50 patients with this particular treatment, you're expected to see one benefit. And depending on the clinical situation, um, an NNT of 50 may be perfectly acceptable. Let's say that the disease that you're treating is um, is a very severe cancer of some sort. Now, if I were to treat 50 patients and I was able to successfully treat one patient, I would think that would be a uh, clinically significant benefit. Now, in this case, the number needed to treat for dental implant is 25, meaning that if you give antibiotics to 25 people, you will prevent one person from experiencing an implant failure. Right? So everyone has to decide whether this is clinically relevant to you. But in my experience, if I could prevent one implant failure in 25 patients, I would certainly take that. Let's look at another study that was a 8-year randomized prospective clinical study, which is a long-term study that looked at close to 3,000 dental implants placed in 800 patients at 32 different study centers. And they broke down different groups into antibiotics versus no antibiotics in both smokers and non-smokers. And what they found was that patients that did not receive any antibiotics, that the failure rates were significantly high, especially in smokers at 14.9% versus non-smokers at 7.5%. However, in patient groups that received antibiotics, the failure rate was significantly less in both smokers and non-smokers at 4.7%. So this study tells us that that there is an advantage to using systemic antibiotics, but especially in smokers. Now, what about patients that are allergic to penicillin? Here's a study that have looked at implants placed in a private practice that was followed for at least a year, and penicillin allergy was based on patient self-reporting. And the regimen for these implant patients was either amoxicillin 2 grams 1 hour before, and then post-operative 500 milligrams of amoxicillin 8 hours later. And those patients that were allergic to penicillin, they were given clindamycin 600 milligrams 1 hour before. So the results show that patients that were given amoxicillin, there was a 0.8% failure rate versus patients that were given clindamycin, failure rate was 2.1%. And the penicillin allergic patients, their failure rate was 3 times higher than the patients that were given amoxicillin. And in immediate implant placements, the patients that were given clindamycin, their failure rate was staggering 10 times higher. So the question that we have to ask is this an issue of patients that are allergic to penicillin, or is it an issue of clindamycin that's not being fairly effective? So to answer that question, here's another study that have looked at patients that were allergic to penicillin versus patients that were given amoxicillin. So this is a cross-sectional study that have looked at penicillin allergic patients, which was only about 6%. And, and there was about a 9% implant failure that was noticed. And once again, that the regimen that was given was either amoxicillin versus clindamycin. In amoxicillin patients, the failure rate was at 8%, and in clindamycin patient, the, the failure rate was once again a staggering almost 25% failure rate. The clindamycin patients had about 4 times greater chances of implant failure than in amoxicillin patient groups. So once again, let's see how effective clindamycin is. This is a relatively small study. It is a prospective randomized control study looking at, once again, straightforward implant placement. of using clindamycin versus placebo 1 hour before implant surgery. This was performed by one surgeon, blinded uh, to the antibiotic versus placebo, and a different observer who performed a postoperative assessment at 1, 7, 14, 28, and 50-week follow-ups, and only 31 patients in each group were measured. The results tells us that in the placebo group that there were 2 infections with no implant failures, but in the clindamycin group that there was 1 infection that resulted in 2 implant failures. And statistically, there were no difference between the placebo and the clindamycin group. Once again, even though this is a small n study, this tells us that maybe clindamycin is really not effective at all. So the question that I have is why are we using clindamycin as a go-to antibiotic regimen for patients that are allergic to penicillin? And I think it has to do a lot with the American Heart Association guidelines for the prevention of endocarditis. And for the longest time that they've advocated the use of clindamycin 600 milligrams before any oral manipulation. And as late as 2007, clindamycin was still on there, and this was still the go-to antibiotic regimen. However, in 2021, the American Heart Association changed their guidelines completely, and they removed clindamycin completely from their recommendation. And now that they're recommending azithromycin or doxycycline. Okay, so just keep that in mind, um, and just try to move away from clindamycin in your antibiotic regimen. So, in conclusion, I would recommend that you consider non-narcotic analgesics to manage postoperative pain in your patients, primarily focusing on ibuprofen and acetaminophen combination. Also consider preoperative and postoperative chlorhexidine rinse for 2 weeks. And on a personal note, I would recommend a thorough manual plaque control after the cessation of the chlorhexidine at 2 weeks, especially when patients have healing abutments that are exposed that they need to clean. Because the worst thing that could happen is if patients show up later and they have plaque all over their healing abutment, and there's a high likelihood of implant failure at that point. Also consider systemic antibiotics for routine dental implant surgery, and strongly consider systemic antibiotics in smokers or other systemically compromised patients. And the antibiotic regimen that you should consider would be amoxicillin, 2 grams before dental implant surgery. And for those patients that are allergic to penicillin, either azithromycin or doxycycline would be highly recommended as well. And if you have any further questions, you are welcome to reach out to me, and I'll do my best to respond to you. Thank you for your attention, and have a good day.